The commission will now come to order. Fellow commissioners, included in your packets are copies of the minutes from the December 21st meeting. You've all had a chance to read those minutes, so I'd like to entertain a motion for approval. Do I have a motion to approve the minutes? Motion? Second? Okay. All in favor? Any opposed? Okay, thank you. Ladies and gentlemen, we're short a couple of commissioners. Fran Phillips, who was our vice chair, has taken a full-time position as the health officer for Anne Arundel County. The ethics officials have told her that it would be incompatible for her to serve as vice chair of the commission, serve on the commission at all, and at the same time hold that public position. So with regret, and I mean that with all sincerity, with regret, we've had to accept Fran's resignation. I want to publicly thank her for her service on behalf of the people of this state. I especially want to thank her. I will say so to her after this meeting privately, but as chair of the commission, I can tell you that she has been extremely valuable in giving me very heartfelt advice and counsel, a very quiet counsel. You all know from your meetings here that she had no difficulty asking the exact right questions at the right time, and that has helped to illuminate a number of the issues that we have to deal with, some of which are very, very complex. I would like to add, though, that we haven't heard the last of Commissioner Phillips because she's agreed to continue to serve as co-chair with Commissioner Sargent of the CON Modernization Task Force, which is, that work is now underway. One more point, Maureen Carr York has also had to resign. She submitted her resignation to Governor Hogan. She's been appointed as a judge in the Orphans Court in Anne Arundel County, and she's decided that given her responsibilities as a judge, that serving on the commission was not possible. Once again, we lost a very fine commissioner, and once again, she is performing a public service for our citizens. Now, the good news here, at least for many, certainly good news, is that I'm very happy to announce that Dr. Andrew Pollack will be the new vice chair of the Maryland Healthcare Commission. Dr. Pollack served on the commission from 2005 to 2008. He rejoined the commission, being appointed by Governor Hogan in 2015. He has an extensive record in the medical profession. He's a professor of orthopedics and chair of the Department of Orthopedics at the University of Maryland School of Medicine. He also serves as the Chief of Orthopedics for the University of Maryland Medical System. In the past, he served as chair of the Board of Specialty Societies for the American Academy of Orthopedic Surgeons. Currently, he's treasurer of the American Academy of Orthopedic Surgeons and is immediate past president of the Orthopedic Trauma Association. His clinical training, his extensive knowledge of the commission's responsibilities, his very, very active and pointed participation in the commission meetings, his experience in delivery reforms, which are right now a major project underway in Maryland, makes him an ideal person in our view, my view, to serve as vice chairman. So I would like to ask you to join me in recognizing Dr. Pollack as our new vice chairman. Do you have anything to say? I mean, usually you do.
Yeah, it's uncommon that I have nothing to say. I have nothing to say. I'm humbled and honored to serve in this capacity. And Fran left some big shoes to fill, and I will do my best.
very much. Dr. Pollack. Commissioners, you have all received written updates from the centers. You've had the opportunity to read those updates. Do any of you have any questions on any of the written updates that you received? You do, Michael.
So Ben, in terms of when you talk about MCDB, so MCDB is that our all payers database?
We use it interchangeably between MCDB and all payer database.
Okay. And so basically the update is that the data's coming in, it's coming in pretty well, it's whatever. Do you have any update for us on what the situation was in terms of trying to think about how to deal with the lack of self-reported data, or how big a problem that is, and is there any strategy for either imputing that data or reweighting the data we have, or some technique to kind of fill in that gap?
So we have been working internally on how, so the problem is that we're missing a significant portion of the privately insured due to a Supreme Court decision in 2016 that that ruled that state requirements for data submissions on self-insured ERISA-protected firms were prohibited by the federal law. That meant that the 20 or so states that had APCDs lost in the range of 25 to 40% of the claims volume that they collected. In Maryland, I think we're saying about 25% of the privately insured market is, maybe it's a bit larger. Ken, if you want to come up to the front, we can maybe have a more of a conversation about this. So we've been working on two fronts. One, specifically with our partners at HSCRC, which are using the all-payer claims database to support some of their estimates back to CMS on the impact of the all-payer model on the total cost of care for the privately insured. More generally, we've also been looking at how the now restricted APCD can be used to the full range of purposes. And Ken, if you wouldn't mind, can you briefly elaborate certainly on the first step we're using?
So the ERISA data is about a third of our entire APCD database.
Does that include the public players as well, like Medicaid and Medicare?
No.
Just the private?
Yeah.
So a third, and we figure public versus private, is it like nationwide where it's roughly 50?
This one, right? Maybe, I'm not sure. I will double check that and actually get back to you. But for sure, I know it's about a third of our.
About a third. So I'm just trying to, in my mind. So we maybe have a problem with maybe a total. And do we have Medicare and Medicaid data in the system?
We do have Medicare and Medicaid data.
So we might be looking at something ballpark. We can clear that up later, but maybe 15% of the data is missing.
Maybe
Total.
Yeah.
Okay.
But I have been reaching out to self-funded payers to report voluntarily.
Yeah.
And some of them are slowly reporting, coming back slowly. We have from one.
And this is a voluntary report?
Voluntary, yes.
Okay.
Volunteer. I've been reaching out to payers to actually submit voluntarily. But we have not heard from the Department of Labor concerning.
I wouldn't think you would.
Yeah.
So, yeah. Okay.
Yeah,
Don't hold your breath on. Yeah. Okay.
Right. So we haven't heard from them.
Yeah.
As you know, we have submitted comments about reporting, to the common data layout.
Right.
That's a common data that the Department of Labor in their Schedule J, will actually have. They're going to roll out in 2019, but we haven't heard from them.
Okay.
So, so the plan is to reach out, to groups or payers to actually report their self-funded ERISA voluntarily, and we have very limited success with that. But it's difficult and it's challenging, so we continue to do that.
Okay. And is there anything on the front of thinking methodology? I mean, this is not I mean, this is sort of a severe one because this is pretty critical data. But,
Linda, why don't you sit down?
yeah, sure.
I think Ken skipped over the most important part, which was we've been working with HSCRC, and we did in fact develop a model to estimate the number of missing ERISA lives and to estimate cost expenditures for them, because annually HSCRC wants to report what is the total per capita for the privately insured market.
Right.
And so we worked out an estimation technique where we figured out which population would match most carefully, and we did a lot of analysis for that.
Okay.
And surprisingly, it was the fully insured market,
Okay.
and the large group fully insured market, and then
But still has
and we-
traditional insurance, so they're not exempt.
Right.
Okay.
Right.
That
And
makes
because
sense.
it's nice and diverse,
Yeah.
it's a nice diverse group, just like the self-insured, which
Right.
are the Walmarts, as well as, you know, the
Right.
Shishi things. And then we used the MEPS-IC. Ken was very creative with us, wonderful with it. We used the MEPS-IC to look at, you know, because the MEPS-IC reports on self-insured and the cost per premium, you know, the premium cost
Yeah.
for in self-insured companies
Sure.
in Maryland, you know, and so we were able to
Nice.
actually use Maryland specific
Kind of
data, and
control
we would
total. Good.
yeah, and so we were able to do this projection. We've shared it now with them for a couple of years, and we would be happy to share it with you.
That would be great.
See.
That'd be great. Because it's, you know, I mean, it's critical, but this is not, I mean, census has to do this, you know, people, as you can imagine, on immigration status, some people don't want to fill that out.
No.
And, you know, income and other things. And so you have to have this way, you either reweight your data or you build a little model that will project based on, like you say, match them up statistically, match them on income, and then say, well, this 45-year-old of certain, you know, the ones we know see the doctor 4.5 times a year, so we're going to assume 4.5 into the new population. Okay, cool. Yes, I'd love to see the methodology.
Okay,
So
great.
sort of just to summarize, then, so we're meeting the needs of our partners in terms of total cost of care. We have developed a methodology with HSCRC. I would call it a working paper. We haven't just shared between the two commissions, but we'd be happy to share it with commissioners.
It's workbook, actually.
And two, the broader initiative working with other states is to try to generate some initiatives that make it easier for self-insured employers to contribute, and that's just getting started. It's going to be very challenging.
I don't want to take any more time on this because you've got your regular full agenda, but is there some way for states to share this? I mean, there's some very creative things we've seen come out of Minnesota, state of Washington, things like that, where, I mean, who would probably have similar populations and face similar sort of challenges, and just to see, you know.
NATO. We're going to
NATO,
submit.
okay.
We're going to submit it to NATO.
And NATO is the national.
National Association of Health Data Organizations.
Okay, and so that is the big all-payer database out of Salt Lake or wherever.
Colorado, everybody.
Got it,
yeah.
got it.
Simply enough, Salt Lake, yes, that's correct.
It's going to be in Salt Lake, actually.
Okay, right.
So, yeah, I mean, I think there are three organizations that are actively engaged in trying to bring entities together, not just states, NATO, ENRI, of which we're also members, and the APCD Council, and then the National Association of State, NASHB, is also actively engaged in trying to build some momentum. This is clear that I think states are going to probably have to take some initiatives on their own.
Okay, great, thank you.
Thank you very much. Thank you, Linda. Thank you.
Yes, actually, they participate with. They're a little behind us in some stuff, but we've shared a lot. Kyle, we know Kyle really well.
Yeah, Kyle.
Yes, they are.
Thank you very, very much. Thank you very much. Ben, you have some other updates? Excuse me, somebody else?
Ben, any updates on the rural healthcare work group?
The Rural Health Work Group delivered its presentation to Senate Finance Committee on Tuesday of this week. Dr. Joe Ciatola, Ms. Sear and Paul. I was in a health insurance exchange meeting, so Paul Parker presented for the commission. I understand the presentation was well received. There is some legislation being developed that would create statutory authority for a collaborative in the Midshore area. That's still being worked on. I expect that bill would be introduced shortly. It would likely come out of Senate Finance Committee with Senator Hershey from the Eastern Shore taking leadership, but with support from Chairman Middleton.
Anything else? Ben, do you have any other updates?
So I know I've shared this with the commissioners already, but I wanted to emphasize that on January 8th, the federal government and Maryland reached an agreement to extend our existing total cost of care model for another year. CMS and HHS indicated that they needed some additional time to consider data for 2017 as they considered approval for the total cost of care model, which would now begin in January of 2020. At the same time, they indicated that the programs that are part of the total cost of care demonstration will continue to work on those in the interim. The most significant from the standpoint of the Healthcare Commission is that we are collaborating with the Department of Health in the primary care model. The plans are for that to roll out in 2019, which would indicate that we would have to have, as part of the total cost of care demonstration, the primary care program would have to be launched, that is, applications for primary care practices to participate would have to probably be launched in the summer if all of this is to take place and start in 2019. We will be providing an update to the Commission probably next month. It may be, however, in written form if we have that available beforehand, but give you a view of how the schedule is changing as a result of this agreement to delay the launch of the overall model for a year.
Commissioner Sargent?
Thank you. When you say we're collaborating, can you elaborate a little on what that means we're doing, as the commission is doing?
So the commission staff is working with Dr. Half in planning for the engagement of primary care physicians. We're working with the CMS staff in the solicitation documents that CMS will issue. We are working with the department in outreach efforts to engage and inform primary care providers in the participation in the model. We will likely have a role to play in the care transformation activities. Should this be approved, our role would be identifying and working with organizations that would assist the practices in meeting the requirements in the new model going forward. Those have not been agreed to, but that's some of the discussion that's been ongoing with them. We would inform you as this moves forward. Clearly, the delay has given us more time, I think, to plan this more carefully as it's a significant state initiative, judged critical to the total cost of care effort overall, that we need to have a very highly engaged primary care workforce in order for us to succeed in this new demonstration over the next 10 years.
So they're willing to go forward in a one-year extension and everything except the primary care model, which they want more data. That sum it up?
I think that's not quite correct. They are delaying let's put it this way, they're extending the existing model for 1 year. During that time, that'll give them an opportunity to look at the results from the existing model. They are continuing to evaluate the proposal that was submitted by the state of Maryland in August 2017 to establish this new total cost of care model. As part of that total cost of care model is a primary care program that was envisioned to start in July of 2018. It's now been assumed that would start in 2019, about a year before the full TCOC would be launched. But because it's all tied together in a model agreement, we can't start anything until that model has been agreed to by the federal government.
But the updated model is kind of, we're just going to stick with the old model 1 more year while and the primary care is going to be running forward.
That's correct. Everything being delayed for a year. It could be less. It could be less. It could be less. But I'm saying a year.
Any further questions? Ben, anything else? Mr. Parker, yes, you're providing an update for us.
Chairman Moffett, members of the commission, wanted to briefly update you on a matter that came up last year. Commissioner Phillips asked us to provide information on a matter concerning nursing home services in the state. NMS Healthcare, which is Neiswanger Management Services, operated 5 nursing homes in the state of Maryland, and last year they were charged by the state of Maryland with inappropriately discharging patients. It was called dumping of patients. They were discharged to inappropriate settings, and it appears that the motivation was to free up space for more lucrative types of patients. One of their facilities in Hagerstown was decertified by CMS for Medicare and Medicaid participation, and that facility closed last summer. The patients were transferred to other facilities. So Commissioner Phillips asked that we come back to the commission with updated information as the story developed. We received notification in December that the owner of the 4 health care facilities that were still operating, Sabra Healthcare, is replacing NMS with a new operator, and they're planning to do that effective in February 2018. Those are nursing homes located in Silver Spring, Wheaton, Hyattsville, and Annapolis. And down the road, there is a plan to also reopen the Hagerstown facility, and that will also be under a new ownership. So, you know, effectively, NMS is basically being removed from the state as a nursing home operator. So I just wanted to provide that update.
Okay. Thank you very, very much, Mr. Parker. Sue Ellen Weedman, I understand that you have a new assistant attorney general. You want to?
We do. I'm glad to introduce Sarah Pendley, our new assistant attorney general. Sarah's been with the AG's office at the Department of Health for almost 20 years, 10 years with the Board of Nursing.
All right.
Before that, with the board position, so she has lots of experience that is easily transferable to the commission. And Ben is not the only person here who has an attachment to the state of Iowa. Sarah went to the University of Iowa Law School, so there's been 2 people with an Iowa connection. So y'all will join me in welcoming Sarah.
Welcome aboard, Sarah. Thank you very much. And Linda Bortinska, you have an announcement as well. So here we are.
So I'm really happy to introduce Debola Akinyemi. Ms. Akinyemi has joined the Center for Analysis and Information Systems as a health policy analyst. Prior to joining the commission, she was chief of the Center for Injury Epidemiology at the Maryland Department of Health, where she was the lead epidemiologist with the Maryland Violent Death Reporting System Program, a CDC-funded surveillance system that monitors the burden of violent deaths in Maryland. Prior to joining the Maryland Department of Health, she was an epidemiologist with the Gloucestershire Primary Care Trust in Gloucestershire, UK. Ms. Akinyemi holds a master's degree in public health from George Washington University and a Master of Science degree in environmental science from the University of Aberdeen, Scotland.
All right.
Please join me in welcoming
Well,
Debola Akinyemi.
welcome aboard. It'll be a great pleasure to have you. And we can share a lot of information with regard to international healthcare performance. Maybe we do better than Britain in certain areas. Thank you very much. Right, bye now. Okay, item 3. We have a certificate of need application. Actually, it's a change in the approved certificate of need for Prince George's Post-Acute LLC. Prince George's Post-Acute applied for a modification to its previously approved certificate of need. The CON is needed to increase because of an increase in the approved cost of the project. Kevin McDonald, as chief of the Certificate of Need Division, is going to present the staff recommendation. Kevin, thank you very much.
Thank you and good afternoon. Prince George's Post-Acute, 150-bed nursing home, again approved in April of 2014. It's part of the Future Care Health and Management Corporation family of 13 skilled nursing centers in the Baltimore and Washington, D.C. area. Has been before the commission once before for a modification and has had some, although they're very close to completion now, has had some difficulties with this project as it's gone along, having had to ask for extensions on all 3 of its performance requirements, as well as that prior cost increase. The original approval was for about $19 million. The subsequent project change brought it to about $27.9 million, with that increase being roughly split between a bad cost estimate and a changed design and increased space to accommodate a different patient mix than they had originally planned for. They are over 70% complete at this point, anticipating a use and occupancy permit by the middle of April, which is also the deadline on their performance requirement extension. To just give you a little more detail on that, the performance requirements we put on capital projects of this nature are 2 years to come to a binding construction contract, and then an additional 4 months from then to initiate the project, and then a certain time period to be able to complete the project. And there have been some delays all along the way on that project. This second request is for a little over $3 million, would bring the total project cost to about $31 million. The additional money will all be funded with cash. The breakdown of that additional cost is about $1.8 million in building costs, about $500,000 in A&E, and then the bulk of the remainder is in permitting costs, upgrade in the physical therapy equipment, and working capital increases. In looking at the question Commissioner O'Grady asked last time about, how can we avoid these kind of things in the future? What brings us to this point? As we look at the history of the project, the original cost estimating, we have as explained before, this Marshall valuation system. for looking at appraised cost. And the initial project came in with a significantly low measurement of MVS, which probably should have been a red flag to the applicant and probably, frankly, should have been a red flag to the review staff. But we didn't question that. And at the time, it was about 28% under the MVS projection. I was relatively new then. I didn't really know how much credibility to put into MVS, frankly. I hadn't worked with it before. The modification, the original modification came in very close at within 2.2%. Now the project is about 12% over. So it is going to be costing a little more to produce than probably it should have. However, if we look at that from a public policy perspective, it doesn't really have a public policy impact because of the way rates are paid. Medicare reimburses based on patient acuity. Medicaid has a ceiling for capital that this project is already over, and they will not be reimbursed anything additional, frankly, for either of these modifications, I don't believe. And Medicaid does use the MVS appraisal method for what they are going to pay for the capital component of a facility. However, they do that after the project has been built rather than prospectively based on the specifications as the applicant has to do and as we as staff do. Passing along of increased cost to patients who are paying out of pocket or private third-party payers, yes, there would be an element of increase to those populations, but they do have choice. They can decide that they want to pay that extra difference, or they could go to another facility. So staff is recommending approval of this project change because we don't believe that these changes would really have influenced your initial decision. The project does not approve any additional beds. Since the location and the nature of the project isn't changing, it wouldn't change your findings on the need for the project or its impact on the health system or other providers. And despite the cost escalation, the project viability still appears to be there, and the applicant has demonstrated the availability of the funds to pull it off. So therefore, we recommend approving with 3 conditions regarding signing the MOU for Medicaid provision, meeting and maintaining those levels of service specified in the MOU, and demonstrating that Prince George's Post-Acute has established collaborative relationships with other types of long-term care providers in Prince George's County. And those would all be things that needed to be accomplished prior to our issuing first use approval. With us today from the applicant is Les Goldsmith, the VP of Operations for Future Care, Jack Eller and Howard Solins, attorneys for the client, for the applicant, and Andy Solberg, their consultant.
Welcome, especially Mr. Goldsmith. Thank you very much. Do I have a motion to approve? We have a motion. Do I have a second? Second. Okay, discussion. Commissioner Thomas.
So if I could direct your attention to page 4. It could be that we've already discussed this, but I don't know, it just jumped out at me. And it has to do with the architect and engineering fees. But it's a footnote of $500,000 in potential liability to these entities. So my question goes to, I guess, doing business in the state or doing business in this county. What are we looking at here when we see these? They describe it as miscues. What are we looking at? We're looking at doing business in the state of Maryland, or business in Prince George's County, or something unique to this particular project?
I think I'll have to defer to the applicant on that question.
Mr. Solins, thank you very much.
Thanks very much. In identifying the fact that there were things that the applicant wanted done differently or expected to be done differently, they have put folks on notice that of a potential insurance claim. It's the architect is financially responsible. It was the engineer who subcontracted to the architect who was the issue. This is a company that is, as Dr. Moffat said, extremely experienced in operations. There aren't that many new facilities that are built in Maryland and in a lot of states. And this is a project that is really has certain, it's not your typical facility in the sense that it's designed for a lot of high acuity, high rehabilitation. It's going to be located very close to where the new Dimensions Hospital is going to go. It's very close to staff access. So these are experienced folks. There's nothing that was done that would suggest that people shouldn't be doing business, but there is a claim that has been put into an insurance company. And that won't affect, as Mr. McDonald said, the owners are absorbing 100% of this cost out of their own pockets. They're not even borrowing the money for the excess.
And there's no taxpayer involvement here at all.
Right. They're absorbing this cost.
Sure.
So just for clarification, in the world I live in, $500,000 seems like a lot of money. Sure. But it might be percentage-wise not that much in the context of this project. So I'll come back to my question: is it typical? Is it challenges of doing work in Maryland? Are you unique to the county? Or unique to just this particular project? It was unique to this particular project. Every once in a while, like a lot of people here have been doing this a long time, every once in a while, something happens that you wish didn't happen. And that's what happened here. And so then part of what you do is you take advantage of it to the best you can to not only fix the problem, but make improvements. And they're very proud of the facility. It's more than since the passage of time, they're more 80% done, and they are set for use and occupancy in April, and will be a very exciting addition to Maryland. Thank you.
Oh, yes. Commissioner Pollack. Yeah.
So I'm supportive of the staff's recommendation here. I want to, there's a part of this that still bothers me, and I know I say this with a lot of these applications that come forward, but I just want to get this point across again as we start to think about how we might reform the CON process going forward. So we heard clearly that the project's merits are unchanged, that the need is clear, that the cost at its current level would probably have been approved originally had it been proposed that way, and that the difference is being financed out of pocket. So it gets to me, how is this our business even? Because there is no compelling state interest here that I can see in approving this, in addressing this secondary CON question. Right. So in the spirit of informing our decisions going forward with regard to how we might revise the CON process, can you give us a sense of what the increased cost was in terms of attorney's fees, consultants' fees, et cetera, to bring this project here? It seems like your project costs ran up, and then we just ran them up a little further.
Well,
Not intentionally, but through this process.
The legal fees and consulting fees did get to be some tens of thousands of dollars, and every informational question causes a meeting, a discussion. How do you do it? How can we provide the information? What's the best way to provide the information? There's no such thing as a casual question in the certificate of need process because the stakes are high. Andy Solberg and I were in a building in 201 West Preston Street in 1983 where the first set of emergency certificate of need regulations were written. I think Andy wrote them and I gave him a hard time about it. Under the old Health Resources Planning Commission, and there are still some vestiges that I think are as frustrating. Don't know, but I would suspect to everybody. So, for example, Kevin referred to the 24-month performance requirements, which is typical. For building a new building, they're 18 months. Why is it 18 months and not 24 months when you're building a whole new building? I don't know. You have performance requirements, which have been around for a long time. You get only 1 6-month extension of each one. I've had clients come pretty close to that clip. Never happened over 35 years, but you take away your own discretion. And so you talk about driving up costs. So what happens? I mean, they're going to hit April, but if it would turn out to be May or June, does that mean they have to pay extra fees to accelerate? Yeah, that's a part of it. The performance requirements definitely need a look. You can do phases for a project in your performance requirements, but only if your project costs more than $40 million. Why can't you have a project? Why can't you have a phased capital approval for $39 million? There's a very old joke, which I won't tell, but I'll have to tell people afterwards, about the end of the turkey that's cut off and going into the oven, and how the end of the turkey got cut off and going into the oven. But that's, if you know that joke, that's, there's a certain amount of turkey here, in the sense of things grow up. You can look, if you've known this long enough, you can remember the case that prompted the change in the particular regimen. Very well intentioned, but the look that you're doing is a good thing. And I think I'm looking forward to the conversation. I don't volunteer to serve on commissions because I've got clients in a lot of different directions, but I'm going to try and come to all the meetings I can. And if you take questions from the audience, or I may have some.
Thank you. Thank you very, very much, Mr. Solons. As always, enlightening. Thank you. Commissioner Sargent, sorry. Commissioner Sargent.
Quite all right. So I have a question because Kaiser Health News has a really interesting article on New Year's Eve, actually, titled "Care Suffers as More Nursing Homes Feed Money into Corporate Web." And that article is, I do not believe Future Care was mentioned, but that article is about a couple of, I read it, well, for the rest of the commissions, a couple of arrangements whereby the nursing homes owned nothing. They had managers, they had real estate companies, and they had no assets. And when the care went south, there was nothing to sue. And the question was whether or not that was, and it put in some statistics about whether the care provided in those types of arrangements was as good as it was where just the company owned and ran the nursing home. And the reason I'm raising this is I noticed the structure here is there's a real estate company that's actually building the property and leasing the building to an operating company that holds the certificate of need. An operating company is hiring a management company to do the management, and it looks like the management company, there's an unspecified arrangement where they're assisted by, I think, the National Future Care Company to put it together. I'm happy to see. So my question really is about our process, because it doesn't look to me, when we look at the certificate of need, do we pay any attention to that corporate structure, or do we just look through it at the realities of what's being built? Or is there some point in our structure where we would weigh whether that makes a difference in what we're looking at? Does that question make sense?
I think I understand the question. This is extremely common. It's extremely common, and frankly, we have a process that the commission doesn't have to see, which is called determination of whether a certificate of need is needed for a certain thing to happen. And a lot of those are nursing home transactions, and they are frankly the bane of my existence. Trying to unravel what's going on and write a letter describing what this transaction can be very challenging. And we usually ask for, if we don't initially receive, an organization chart. But how does all of that fit into our recommendation? I think if we're looking at an existing provider, we're looking at the track record of whoever the operator is in that situation. And at least I consider that more important than the real estate company that's involved. I just imagine, they can probably tell you, but I just imagine the reason the way these things are organized the way they are, number one, to protect the investors from any poor care and litigation that would result from that, to find tax advantages. Those are probably the two reasons you see these things as complicated as they are. There's probably, I don't know, 15, 20% of that might be for logical business reasons, other than those two things I just said. But more than you wanted to hear probably, but in the review process, we try to identify, okay, who's really operating this and what is their track record?
I'm very familiar with these structures. First of all, with respect to what you're about hopefully to approve, Future Care owns all of its buildings. There's no rate, and it's the same people.
The
It's
real
the
estate,
family.
the real estate company owns this building.
They own the building, but Future Care Health and Management and the operating company and the real estate company trace back to the same people. And so there are structures that are structured differently in which you have disaggregated ownership. That's not the case for this project at this time. And when I say at this time, that sounds like something's going to change. No. This is the same families that's been just, and they only have facilities in Maryland. This company does not have any out-of-state facilities. In terms of the overall structure, you see different things, as Mr. McDonald said. It's a very common structure. In terms of how that plays out when national companies come for a certificate of need, your application form requires everybody who owns 5% or more to be identified. There's a very rigorous completeness process. I don't know about other people, but we put in the organization charts and make the disclosures. And then a lot of times then the staff will do searching. And I've had clients who they had questions about what happened in another state because of those charts, and we answer them. And, it's so ultimate, the structures are created because lots of healthcare environment, you can call it the malpractice crisis or the malpractice opportunity, depending on what side of the coin you're looking at. I just want to say that with respect to accountability, many people say that the only thing that is more highly regulated than a nursing home is a nuclear power plant. There are a lot of, and so there is a lot, there's no such thing as kind of hiding from who's really delivering the care. And so, again, I know you not only have a committee having to do with CON generally, but there's a long-term care chapter that Ms. Cole and others are working on, and I'm happy to continue the conversation about the way it is.
Thank you. Any further questions? Any further questions? None. Hearing none, the motion is to approve a change in the certificate of need for Prince George's Post-Acute LLC. All those in favor say aye. Aye. Any opposed? Congratulations, Mr. Goldsmith. You have your certificate of need. Fellow commissioners, the next item has to do with the legislative process for this coming year. The 2018 Maryland legislative session began last Wednesday. Ben and Bridget Zombro, Director of Administration, will give us an overview of the 2018 legislative session and describe how we are going to review legislative provisions that come before the state legislature. So,
thank you, Mr. Chairman.
Bridget.
Good afternoon, Commissioner. There are several components to the legislative process. One is bill review, two, position paper development, administration legislation, departmental legislation, privately sponsored legislation, and then the budgeting process. I'm going to go through each one of these briefly, especially for our new commissioners, so they see the process. We're going to start with bill review. The position of the commission is usually based on stated priorities or statutory responsibilities. The position of the administration and other executive branch agencies, and previous positions that the commission might have taken on the same or similar legislation. There are 5 actions that the commission can take. 1 is a letter of information. 2 is to support the bill. 3 is to support with amendment. 4 is to write a letter of concern, and 5 is to oppose. When developing a position paper, the steps are the position development and drafting process. Then it goes to the center director and legal review. It passes on to the executive director for his review. And then it goes out for commission review to all of our commissioners. And then it is voted on by the commission. The bill review conference calls with the commissioners are usually held on Mondays. Usually Ben or the legislative liaison will send an email to the commissioners with all the relevant bills that they'll talk about during this conference call. If MHCC takes a position paper is required, and sometimes oral testimony is needed. Administration legislation. Administration proposals are of the highest priority. Any amendments to administration legislation should only be offered by the governor's legislative office unless you're otherwise directed. Concerns about language in administration legislation or suggestion for amendments needs to be addressed to the appropriate person on the governor's staff. Departmental legislation. All executive department bills are approved by the governor's legislative office before introduction. No executive branch representative may oppose a departmental bill before the General Assembly. Concerns that arise after introduction should be brought to the attention of the sponsoring agency and, if necessary, the legislative office. Any amendments, which is a non-sponsored department, feels are necessary, should be agreed to and offered by the sponsoring department. Conflicts are usually resolved by the legislative office of the governor. Privately sponsored legislation. We coordinate with the department on positions. The legislative liaisons discuss the varying positions at the weekly departmental meeting on Fridays. Generally, again, conflicts should be avoided by agency. On to the budgeting process. The budget is introduced by the governor and assigned to a budget committee. The budget hearings are scheduled now after we write that. The House Appropriations hearing is February 22nd, and the Senate Budget and Taxation hearing is on February 26th. The budget then moves through the chambers. They make decisions, and if they can't be ratified, they go to conference committee. We put together some dates of interest. January 10th was the General Assembly convening. January 17th, the budget bill was introduced. January 31st, Governor Hogan's state of the state. February 5th is Senate bill introduction date. February 9th is the House bill introduction date. February 16th is green bag appointments. They're submitted by the governor. March 5th is the final date for introduction of bills without suspension of rules. April 2nd, budget bill to be passed by both chambers. And April 9th is sunny days. Special note, several of the commissioners will have appointment hearings before the Senate Executive Nominations Committee, and that committee meets on Monday through March. And I think you wanted to talk about this slide.
Sure. What's the green bag appointment?
So I don't know the history of the green bag, but it is each year the governor has appointments that he makes formally to the legislature. They are supposedly ceremonial, it's delivered in the green bag, and those constitute his nominees for commissions, organizations for which he, so you can be a green bag appointment.
And be a green bag.
You're in the green bag. there is a history, there's a history to the green bag. I just don't know that.
Commissioner Polly? Oh, okay. All right.
So I did want to add a little more information. As you know, we don't have a legislative chief at the present time, so we are sharing some of the responsibilities. Diane is monitoring legislation as she has been over the past year, doing an admirable job and coming up with some good suggestions on how to make this information more transparent to commissioners. Bridget is monitoring the budget bills and helping me keep track of legislation as it moves through the respective committees. We do discuss bills at our weekly staff meeting, and as I said, as Bridget laid out, if we think there's a position the commission should take, we review that and then pass this through the process that we've outlined. We have historically met on Monday at 8 o'clock. I know that poses some challenges for people depending on work schedules or other exercise or other activities they engage in, but I wanted to confirm that that's what we'd like to try to do. Again, this year with one qualification, in that if we have one piece of legislation that we want to consider, we'll likely try to circulate that to the commissioners without a formal meeting, as long as it's acceptable to the chair. I think trying to hold a legislative meeting with 12 or 13 people present for a 15 to 20-minute meeting is not a great use of our time, but I'm certainly open to other people's suggestions, commissioners, on that. But I think generally, if it's just one bill, we try to circulate that electronically with the recommendation that if you have comments, to do a reply to all, so everyone sees your comments and can consider those before the staff position is adopted as a commission position. We're also in the midst of recruiting for a new legislative liaison. We have significant numbers of applicants, and we're going to go through those carefully. The chair will interview the last two applicants, and we hope to have a person in place by the end of February. Now, there's a small chance that we may have to go this entire session without a legislative liaison, and we plan to do so with over staff, assuming some additional duties throughout. But we do have some good candidates. I think all are currently employed, and we, of course, want to get the best person, and sometimes it means being respectful of that person's commitments going forward. Any questions?
I would just like to make an observation on this. I mean, a number of you have very, very specific expertise in certain areas. And assuming that your viewpoint on legislation does not obviously contradict the position of the governor, but can be supportive of what the commission is doing, don't hesitate to consider, volunteering for either an appearance or a briefing before the appropriate legislative body. One of the great things about an independent regulatory commission is that we draw from a wide variety of people in private life who have developed experience in certain areas of public policy, and here we have a very high degree of experience in health policy. So we've got to take advantage of that. And some of us have had a lot of experience testifying before a congressional committee. Some of us have. And it sometimes is enjoyable, and many times it is not. But nevertheless, this is an opportunity to use your talents to the best of your ability in support of the commission's agenda. So just keep that in mind. Contact Ben, of course, but keep it in mind. Well,
we will have to divide up our 3 minutes very carefully.
Thank you.
Thank you very much, Bridget. Any further questions?
So we did want to at least consider some review where we are with legislation.
Right. Yeah, we have a proposed legislation. David Sharp is testifying, delivering our position on SB 17, dealing with health insurance exchange definitions and regulations, information definitions and regulations. Ben, could you fill us in on what the staff is tracking?
So one thing that we have done historically is Diane completes a very brief summary of each piece of legislation that we are tracking. This year, we've decided to move that document to the front page of the commissioner's website. And so without logging in, you can pull up that document. It'll be updated frequently throughout the month. So if you look at it tomorrow, it's going to look different than it will next week, for example. And in addition, we've decided against the practice of circulating bills. There is a link on the bill number. Diane suggested this, that if you click on that link, SB File 4, for example, you don't have to do that, but it'll take you to that piece of legislation. In addition, we'll probably add another feature which will enable you to pull up the document summaries and amendments that will be offered, so you can get a full view of what's happening as it moves through the legislature. Moving to the far right, you'll see that most of the bills that we're tracking currently are ones that the commission staff is not recommending we take a position on. Consistent with the administration's position, I think over the years, those of you who have been here for a number of years, particularly those who are returning after they were appointed by the Ehrlich administration, we historically took a lot of positions in the past. The current administration, as well as, in fact, the O'Malley administration, discouraged organizations from gratuitously taking positions on legislation that they're not directly impacted by. So we're trying to follow that, but certainly, as the chair mentioned, from your perspective, if you think there are things that we ought to be weighing in on, we're certainly open to that. Currently, the main, I'll talk about two areas that I want to flag. One is we do see a number of health information technology bills. One of them is one in which we asked the administration to sponsor. It's a department bill, Senate Bill 17. The chair mentioned David is testifying today. We actually expect that this bill, as proposed, probably will not be the one that, should it pass, will ultimately be adopted. There are some suggestions on tightening it up or providing for some additional exemptions that we've heard from different stakeholders. So what I would expect is there will be something of a work group process that would go on, in which a subcommittee would bring parties together to see if they can iron out a consensus bill. The other piece of legislation, Senate Bill 17, is a piece of legislation that has been introduced by Senator Rosapep, which pertains to the broadened use of the health information exchange, as well as an existing data information structure that's already in place, the prescription drug monitoring program that in a moment I'll ask Angela to tell you about. The other area that we know that there will be legislation on that we've worked with the administration on is the removal of CON authority for inpatient acute rehab services. That bill has not been introduced. We've worked with the legislative drafting committee staff in HGO. They've made some suggestions on simplifying it, which would make it easier for the legislators to understand. We've agreed to that, and we'll share it as soon as it's been signed off on and introduced. We expect that would be next week. The third area is every year the governor introduces a budget reconciliation act that was introduced yesterday. Sometimes it has some impact on MHCC, other years it doesn't. This year, in one of the sections is a provision to remove $8 million from the Maryland Trauma Physicians Fund and deploy it for payments for use for Medicaid reimbursement to physicians. We will be talking with Senate and House leadership about that. As you heard in November, the fund ran about a $10.2 million surplus at the end of FY17. So there's considerable revenue funds in that are not being spent. We had suggested some options. One of them was not used for Medicaid reimbursement. We focused on trauma and emergency services narrowly. And I think one of the suggestions we'd make to the leadership is that while we don't believe that all funds are being spent, we think there are needs under the trauma system that are not being met that could be appropriately financed through a surplus that exists. I can't assure anyone that argument will gather any momentum, but I think it's one that we need to emphasize again, and would do so. So I'll pause there.
Yeah, on that one, is that a permanent $8 million move every year from now on, or is it a one-time?
It's a 1 year 2019 allocation, but I think one of the points that we raised in November was that given the expansion of Medicaid, one of the funding obligations, which was payment for physicians for uncompensated care, had significantly diminished. Now there's debate about whether Medicaid is paying fairly those for trauma services or not. That is being worked out with the department. But one of the obligations of the fund has diminished significantly over the last 3 to 4 years.
Commissioner Pollack?
Yeah, there's the argument that Ben pointed out about the potential need to address other unfunded areas of the trauma equation with the surplus. But the other argument about maintaining the surplus relates to the end of the individual mandate. We saw a change in the insurance profile of the state with the passage of the Affordable Care Act and the resultant burden on the trauma fund, which would be expected in that. A large piece of that was related to the Medicaid expansion, but an unknown piece of it was related to the growth in the individual market. And the repeal of the individual mandate has yet an unknown effect on that. And I think that makes it very difficult from an actuarial standpoint for us to assess what will happen to the trauma fund over the next couple of years.
Sure. Right. It's a very good observation. Okay.
So
Angela?
we have one bill that we want. We don't have a recommendation from staff yet, but we wanted to brief you on that and would get back to you with our recommendation. But we'd like to get your input first.
Thank you. So I'll be providing an overview of Senate Bill 13. This is the Electronic Prescription Records Cost Savings Act of 2018. The general purpose of this bill is to allow authorized healthcare providers to access to patients' complete medication history for treatment and care coordination. The bill requires prescription drug dispensers to electronically submit prescriptions information to the state-designated HIE using existing processes. And these are prescription information on non-controlled dangerous substances. Under current law, dispensers are required to report controlled dangerous substances to the HIE. The law also requires MHCC to adopt regulations in consultation with stakeholders, and I'll provide a little bit more information about that. In terms of the dispensers that would be required to submit drug information, these are persons authorized by law to dispense prescription drugs to patients. These include non-resident pharmacies, some such as the larger pharmacies like Walgreens, CVS. It does not include hospital pharmacies providing prescription drugs directly to a patient, or opioid treatment service programs, veterinarians, and pharmacies that have special pharmaceutical services for assisted living, nursing homes, and the like, are pharmacies that dispense drugs to an inpatient hospice that have granted certain waivers. In terms of the pharmacy data that is currently available right now, as I mentioned, controlled dangerous substances scheduled 2 through 4 drugs are required to be reported by dispensers in the state of Maryland, which is then made available through the HIE. These include OxyContin, methadone, Adderall, and other similar drugs. Also, non-CDS medication is somewhat available through the HIE as well. We estimate about 80% of prescription drug information is currently available through the HIE, and this is made available through relationship with the SureScripts network. However, not all pharmacies or pharmacy benefit managers submit data to SureScripts, so there is a gap in terms of the non-CDS medication. Also, dispensers report anecdotally that less of a burden is in reporting all prescription information. They already have those connections to submit non-CDS data and are parsing, or to submit CDS data and parsing out the non-CDS. This would require all the medication information to be reported to the HIE. In terms of MHCC's role, as I mentioned, the regulations adopted by MHCC to carry out this law will be made in consultation with stakeholders, and these regulations will specify the specific prescription information that must be submitted to the HIE, the time frame for submission of information, electronic means and manner by which the prescription information must be submitted. But as mentioned, these requirements would align with current frameworks that are required for CDS data. Any other questions?
Okay. Very good. Any questions at all? Commissioner O'Grady.
So in terms of current practice, isn't this normally, well, let me back up for a sec. The main policy goal here is to avoid kind of mistakes, drug interactions that aren't captured?
So providing a more complete medication list, yes, would facilitate medication reconciliation and reduce some of those adverse drug events.
And so right now we have a situation where that's done by the PBMs themselves when the person goes in to fill the script, and they sort of block it when they go, or if they've been shopping, they go, no, you've got Oxy from 5 other pharmacies. You can't fill it. And so this is to move it backwards to the provider.
No, so this would impact the dispensers to submit information to the HIE. It wouldn't impact the provider's ability to query information through the HIE to understand the control.
It wouldn't improve their ability to query?
It would improve their ability by providing additional information that's not currently available for non-CDS drugs.
Okay, I'm just trying to think through the policy levers here. So we're telling PBMs right now that they feel that they've probably got this, for their side of the business, they've got this handled. There's no more weird interactions. They've got their algorithms. The person can't get the second drug that is going to kill them. But this is mandating that they give that information to an HIE so that the providers see that in their office through the HIE when they get around, so it's moving up the chain. They never prescribe that interaction, or they're told ahead of time, she's still taking the statin, we could eliminate that, then you could. Is that? Yeah. I'm just trying to get these policy goals kind of straight, because we're mandating something, which always makes me concerned.
Mr. Director.
But they're mandating something, not us.
Go ahead.
So I think the policy goal is, and it really came out of some observations a legislature made, which was that when caregivers see a patient, they are faced with either generating a medication history verbally from a patient or through their own records, which if patients are seeing multiple physicians appropriately, in most cases, that they may only have a partial picture of the drugs that are prescribed. As the state takes on all these commitments with care coordination, the ability to have a complete picture is is very important to any physician that sees a patient. So putting this information available through CRIS would enable any physician or caregiver that saw that patient to have a more complete rendering of that patient's medication history.
Commissioner Pollak.
Yeah, just to elucidate on it a little bit. Delegate Moorheim called me the other day to ask for my support in this piece of legislation. I tried to pull out of him what the downside of it was because I wasn't seeing it. But the explanation for that was he was driven to submit this because he's an active emergency physician. You see patients in an emergency department in an emergency situation. Sometimes they remember what medications they're on. Sometimes they don't. Sometimes under the current model, you can get that information out of CRIS, and sometimes you can't. The degree to which you can improve the reliability of that is huge in your ability to care for that patient. Now, you don't know what they're taking. You know what they've been prescribed and what's been filled. You still know what actually they put in their mouth. But at least it gives you more information in that process. And this seems sort of like a no-brainer along the way in that the infrastructure is already there to report all this. The burden of reporting isn't great. What I don't see here is why is there are lots of pieces of information that are medically relevant that Delegate Moorheim submits that he doesn't call me about. So what is it about this particular piece of legislation that people think is going to be controversial and therefore needs the level of approach, the level of preparation, if you will, that we're seeing in this? Is there something here that we're missing? Is there some regulatory burden that this creates that is more significant than what's apparent?
And so your assessment is, I mean, certainly the medical advantage of having full information is pretty clear, very clear and pretty compelling.
Yep.
So now the question is, I mean, because I've noticed in my own that and I think it's maybe my in-network providers, and I think it's coming from my insurer. They, you know, if I saw a new one, they already had my meds list. It was all.
As long as you're in your network. But if
I believe it was in network.
Right.
And so they
but
were.
If you're in an emergency department
Right.
on the other end of Maryland,
and you're unconscious,
right?
And God knows. So I guess what I'm wondering is, we see that sort of just the practice of care has started to do this, and if you hit if you're in the right silo, you've already got this. And so yes, so your point is, this is an attempt to sort of fill out the rest of those silos that currently, you know, there's no business relationship or other thing going on. But it is mandating, and so again, there is that that's a hesitation to say, why does this need to be mandated versus other ways of doing it? I certainly, you know, as liking data, but I think many of us who have been in this situation, especially if you are consumers of data, you realize where, well, just because you think it would be cool to do research doesn't mean anybody should be mandated to provide you with the data. So it's sort of, so those kind of considerations, I think, have to be put aside. I think the care, it is in some sense mandating also kind of the fulfillment of the original promise of HIE. I mean, it was the unconscious car accident victim who pulls into the ER, and now there's no question. You don't have to run tests for God knows how long to figure out what's in his bloodstream. You kind of, other than the alcohol or other things, you know what's there. So it's that kind of a thing. I guess I am wondering why this rises to the level of full court legislative press. And is there something else, another dynamic here that we're not aware of? Is this a heavy financial burden on those PBMs?
So we suspect there'll be just a marginal impact on PBMs. As you said, there's already the framework there, technical specifications.
Just sending it to another party.
Well, allowing additional information to flow other than the CDS data.
Okay. And is there opposition to this from that industry?
I'm not aware of it.
That was where I left the conversation the other night on the phone, and that is, this will get presented, and there'll be an opportunity for the opposition to present itself, which is why my takeaway from that was that we should stay relatively supportive of this, but not necessarily always with a position
Well, and it may just be a wise legislator lines up all their ducks in a row and gets all their allies in place before there's an opposition. So,
Commissioner Sargent.
So first, a comment. I think it's probably not pharmacy benefit managers. These are the pharmacies that are reporting at the time they dispense. So you might have some independent pharmacies saying that it's burdensome. I don't know, but there are those. It's not just the real big guys, but it doesn't seem burdensome. I have a question about the HIE implication, though. As originally conceived, CRISP, I don't see our friends from CRISP out there, but CRISP was originally a list of medical records you could get, some of which you could get through CRISP, but CRISP was not a repository of medical information about people. As I read this, CRISP is now collecting and storing the prescription information for everyone in the state, for every prescription, because otherwise, who are the pharmacies submitting the information to retain? Is that right?
So, Ben, you can jump in, but my understanding is that the information would be made available through networks or clearinghouses that would then be available for CRISP, and not necessarily stored by CRISP.
Will there not be a single place then, like, so you're in an ER, you want prescription records, are they going to be scattered among a number of clearinghouses, or how does that look then?
So I think remember that the state, like virtually all states, established in part with federal funds, prescription drug monitoring program. So the data system that supports that is maintained by the state for the purposes of managing class 2 to 5 controlled substances. The theory behind this is that the prescribers would submit, as they do today, all prescribers are required to submit to the PDMP. Instead of screening out the non-controlled substances, they would submit all prescriptions to the PDMP system. That information would be accessible via query or other tools from CRISP that virtually all providers in the state use.
So CRISP is still a pass-through.
CRISP is the query, the vehicle to which providers would access this information, but I don't believe CRISP itself would be holding the data, but they would be the entity through which information would be requested. Importantly, I think, is that if a patient opted out, which the opt-out, remember, CRISP is an opt-out enterprise that you're in unless you say no, that if you opt out, then all information pertaining to you through CRISP is not accessible, with the exception of the controlled substances use available through PDMP. So there would be a small tweak that would have to be made in the system so that Ben Steffens opted out, but you would still have any of my controlled substances.
Who's funding the PDMP? That's the state?
Funded.
So the state would pay for any increase in bandwidth for the PDMP for this. It's not our concern.
I mean, I think that the major question that we would raise is CRISP would need some additional funds to maintain.
That's where I was going.
To support the additional queries that, I think you could argue are going to occur because there's more valuable information available now.
Okay. Commissioner O'Grady.
I'm sorry, I'm aware of the time. But so would people other than providers have access? So if I'm trying to do simply planning in the state of Maryland and I'm looking at, I'm the guy who's supposed to work for the governor to figure out how to reduce prescription drug spending, can I use this to kind of follow patterns in real kind of time of what people are doing? And so I run my diabetics and I find in Montgomery they're 15% more on their prescriptions than they are in PG, and I can start to take this apart. Is this under care in PG or over prescribing in Montgomery? Is that available? I mean, this is a nice database for more than the ER guys.
So we've gone through a very long and engaged process, which David, Angela, and others on the team have worked with a multi-group stakeholder work group to develop regulations on use of information that comes through an HIE. And there would be, it's envisioned that there would be a way to eventually request use. You want to
Sure. So
briefly elaborate on that?
our current regs specify the purposes in which someone can utilize or gain access to information through an HIE, treatment, payment, and certain healthcare operations. Depending on the use case that you sort of are articulating that could fall under healthcare operations, we also do have purposes in terms of population health and research that fall under secondary uses that require additional authorization.
Okay, and that's mostly for patient privacy, I assume?
Yes.
But this is data stored in the PDMP then, right? That's not our database.
Right, but it is PHI that will flow through an HIE, which our regulations govern.
Right, we regulate, if it flows through an HIE, we regulate it. But we aren't controlling the underlying database.
We aren't controlling the PDMP, correct?
Any further questions? Okay, thank you very, very much, Angela. Fellow commissioners, we are going to be working on outpatient quality initiatives. And Sebastiana Gianci, is that properly pronounced? Oh, very good. South Philadelphia taught me a lot. Chief of Outpatient Quality Initiative will present the 2018 Outpatient Quality Initiative Plan, which consists of several work streams. Sebastiana, thank you very much, and the floor is yours.
Thank you, Chairman Moffitt, Executive Director Steffen, Vice Chairman Pollock, and good afternoon, Commissioners. Good afternoon, everyone. I am delighted to be here this afternoon to tell you about our Outpatient Quality Initiative and to introduce a little bit more about what we have in store. So I would like to talk to the intended beneficiaries of this initiative to begin with. Those, of course, are the healthcare consumers of outpatient services here in Maryland and outpatient healthcare providers. Our initiative is going to be both outcome-driven and consumer-friendly. We will use reportable, transparent outpatient information on both our consumer and provider websites. We are aiming to use our information to facilitate decisions. Oops, no, I'm not quite there yet. Thank you. We are aiming to have improved decision-making that will ultimately assist the provision of safer, more efficient care for Marylanders. So the purpose of our briefing today is to provide information on 5 items within MHCC's Outpatient Quality Initiative and our framework. So to begin, from the landscape analysis we are currently conducting, I will summarize the profile of the outpatient services here in Maryland. And I'll move on to our proposed methodology and work plan, and then move towards what we are envisioning for our strategic engagement and our next steps. So this initiative is really aiming for a dual approach. We're not only trying to present fair and balanced reporting, which is critical for both consumers and providers here in Maryland, but we are also hoping to adopt an approach that says we can and we must do better for outpatient quality here in Maryland. Before I get to that, I'd like to just go over our definitions. I've noticed there's a lot of them. I just want to make sure we're all on the same page on them. So these are the definitions that I'll be using today. HOPD is the hospital outpatient department. ASF, ambulatory surgical facility. This is really the freestanding facility that consists of 2 or more operating rooms. The POSC would be the 1 operating room, physician outpatient surgical center. Sometimes these don't have operating rooms, they're just procedure rooms. And for our purposes, really, when I present data, I'm going to be combining those 2, and I'll be calling those ASCs. The ASCs have all of the freestanding ambulatory facilities, and they are comprised of the ASS and the POC. Sorry for all these acronyms. The freestanding medical facilities, the FMS, are also going to be discussed. So from our ambulatory surgical facility survey, we have a profile from 2015, and we see 47 HOPDs are providing 13% of the total surgical outpatient care here in Maryland. The other 87% consists of the ambulatory surgical centers and the FMS, the freestanding medical facilities. Those freestanding medical facilities, if I'm not mistaken, I believe they're Queen Anne, Bowie, and Germantown. And if you look at the 87% specifically of the ASCs, we see that the single specialty ambulatory surgical centers are really the majority of the ASCs. But that being said, the limited specialty ASCs are increasing rapidly. From 2011 to 2015, they've increased 43.5%. This limited specialty is speaking of 2 or 3 procedures that may be related. The multi-specialties have a wider array of specialties that are happening in them, and they are also increasing as well. So next here, oh, I'm going to go back to that. Okay, so here is a few preliminary analytic runs that I've done. This is using some Qlik software, it's kind of akin to Tableau, and principally looking for changes in surgical case volume in ORs. And I looked at the years 2010 to 2016. And there's really nothing new here. This is just saying that from our HSCRC data and the MHCC surgical survey, we can show that the national trends of movement to outpatient settings from inpatient settings are also bearing out here in Maryland. So we see a 23% decline in hospital inpatient surgical case volume in ORs. We see in the HOPDs an 8% increase surgical case volume. And for the ASCs, which we really only have the 5 years here, 2016 is not currently available, but we show a 7% increase. So I wanted to give you a sense of what Maryland currently is seeking for requirements from HOPDs and ASCs. And primarily, these requirements come from CMS, the Centers of Medicare and Medicaid. And even the CDC NHSN requirements for the affiliated hospital, these are the healthcare associated infections, or the HAI gold standard set. Those are mandated by CMS. So all of this work is really directed by CMS. This is what Maryland is currently doing. We have met with OHCQ colleagues there, and we've went over the current requirements in the infection control worksheet, and we're trying to see how that might move forward in terms of reporting. CMS also has 2 measure sets. We have an outpatient measure set and an ASC measure set. I have all of the measure sets should we want to look at them, but what I'm first trying to do is to see where they overlap, those 2 sets, and I'll explain that in a moment. So moving into the work plan that we're proposing for the OQI, methodologically, what is our framework here? We're trying to follow the data and see where it leads. I've already dug into some of the HSCRC files, the case mix data, the MH file, the OP, and the FMS file, also APCD. And we've been part of many national work groups. We are, I'm specifically on an HCUP work group. That's the Healthcare Cost and Use Project at AHRQ, the state inpatient database, where we're trying to do some interesting comparisons between outpatient and inpatient here in Maryland from that. We're looking at CMS's OAS caps, I'll speak to these a little bit more detailed in a moment as well, and CDC. We're also trying to learn from other states, get data from other states on this. You see here that Michigan's Surgical Quality Collaborative has a surgery and opioid messaging campaign. So we're going to be learning from their lessons and see if they have a best practice that we could recommend here as well. Lastly, we will coordinate closely with the MHCC Ambulatory Surgical Facility Survey team and work closely together as that moves forward. So what are we going to do here? For the first year, we are targeting really the surgical services. So we're proposing concentrating on reporting for HOPD, ASC, and FMS. We're going to complete the landscape analysis that I was mentioning. And the ultimate goal is by the end of 2018 to have an outpatient guide. It may be called an HOPD ASC guide. I don't know exactly what it's going to be called now, but to have that up on the MHCQR site. We are hoping to, for strategic engagement needs, we will be continuing to reach out. We're going to be reaching out to the associations quite a bit as well. We're new members at MASA, which is the Maryland Ambulatory Surgical Association, and ASCA. This is the Ambulatory Surgical Center Association. That's a national association. The other two acronyms here are really Urgent Care Associations of America. I'm actually happy to report that just this past Tuesday, my QI submission was accepted at the UCAOA. That's the Urgent Care Association of America. And so I will be speaking at their annual conference in May. And in subsequent years, we're hoping to dig deeper into urgent care. So we're trying to lay the groundwork as of now. And I know my colleague from CQMR, Courtney Carta, will be doing a Maryland inventory on urgent care centers this year. I'm also hoping to look at subsets of ASCs, for example, the cosmetic ASCs. I've done an initial scan and it's looking very interesting, and also hoping to engage those in oral surgery. So we have not yet slated dialysis and birth centers, but I'm hoping to have that discussion as well, perhaps in year 2 with you all. So out of those measure sets that I was mentioning before, the CMS measure set, these are the 6 measures that occur concurrently on both sets. So we will start here and we'll be able to highlight a nice comparison in our data between the ASCs and the HOPDs on these 6 measures. Retiring in 2019 will be the last 2 here, and so we'll just follow CMS's lead on that. When they take them down, we will as well. Interesting to note that the influenza vaccine coverage and the safe surgery checklist are really the only 2 measures that are mandated here that occur in all ASCs and HOPDs. The others are specific to colonoscopies and cataract surgery. That being said, all of the other measures on the measure sets we will be reporting on as well. So some other data ideas that we initially have from the HSCRC inpatient file. We've had a very interesting look at 2 specific measures that we found there that describe a window, a 72-hour window of admission from an HOPD. So from transfer inpatient from within the hospital from the outpatient department, and then also that 72-hour window from the ASC, the transfer out of the hospital. So we're intrigued by the idea of cutting this data by the source of admission, presenting it perhaps the urgent and the emergent admissions compared against those scheduled admissions. And this is something I hope to bring to you the next time I speak. We're currently validating the process of how these measures were developed right now. Another idea is on the patient disposition, to cut it by the patient disposition, and we're specifically interested to look at the expired category there as well. And as we were speaking about the MCDM, the All Payer Claims Database, we are also hoping to use this data and perhaps the per member per month charge. I know that data includes ambulatory surgical centers, critical access, hospitals, clinics, and home health outpatients. So we're hoping to distill it down to really how it matches with the data that we're going to be presenting. So lastly, the CMS OAS CAPS. The CAPS is a, in home health, there's a few other CAPS as well that they have. This is the Consumer Assessment of Healthcare Providers and Systems. OAS stands for Outpatient and Ambulatory Surgery. So they have this going live. It was supposed to actually roll out this month. And a lot of the HOPDs and the ASCs were slated to do it. And they're also sharing voluntarily their reporting on it currently. So I believe we can use this data for reporting, the voluntary reported data this year, but it will be mandatory in 2019. It will cover communication, care, surgical prep, post-surgical. Very interesting that it will have an overall rating. So this will be very useful to consumers as as they choose their ASC and their HOPD. So moving into the next steps that we're envisioning. I think Ben mentioned last month that I've been out doing some state visits. I wanted to tell you a little bit more of how those developed. Meeting with the Maryland Ambulatory Surgical Association in their annual meeting on November 1st, I quickly presented and introduced the OQI, was able to meet a lot of HOPDs and single and multi-specialty ASCs and was invited out to see them. This has been great for my learning in this area. Definitely, learning curve is vertical right now, so it's great. It was also suggested by MHCC leadership that I check out some of the rural serving HOPDs. So in the coming weeks, I'll be going to Union Hospital in Elkton and Peninsula in Salisbury. And those serve various portions of the Peninsula serving the south of Eastern Shore, and Union serving a lot of rural citizens in the northern Eastern Shore. I think I mentioned this already, that I was at the annual meeting. Andrea Hyatt, the president of MASA, we've been in close coordination with her, and we did a joint exercise, a feedback exercise on, and she sent out this 10-question, it was a 10-question small survey that really was aimed to help guide the development of the relationship between MASA and MHCC. It was nice that we had questions from 4 MHCC departments, and we currently have about 15% of those surveys back. We just had the deadline to receive those, and once we go through them, we will share with our colleagues here internally and with you all. The other idea, really, speaking with Andrea, she was very interested in finding ways that ASCs could learn from their own experience when things go wrong. And I was in a conversation with her and recalled work that I had previously done with WHO, when I was with WHO, and we worked with the Canadian Patient Safety Institute. And the Canadian Patient Safety Institute has put together a tool. It's called the Concise Incident Analysis Tool. It is basically, it's an RCA light or an FMEA light, and it distills the RCA, which is a root cause analysis, down to 4 key areas. And the idea here is that there is vetted content from AHRQ and in this tool from Canada that we could tailor with a Maryland work group to really be useful in Maryland ambulatory surgical centers. And this was really developed first as a request from MASA of how can we learn from our own mistakes and what tools can we use. So we'd like to put together a work group in that regard. So this slide is really giving a sense of what the web pages will look like. The consumer-focused quality reporting, the resource listing possibilities, these are mirroring the current consumer website on that CQMR administers, the Center for Quality Measurement and Reporting here, administers, and we would like to add to them. And what are some of the ideas that we have? So having gone out to the field and hearing from the practitioners, some ideas that came to mind were listing the number of certified anesthesiologists, the CRNAs perhaps at an ASC or an HOPD, and having that be something that a consumer can really grasp and say, yes, this ASC has a certified anesthesiologist. But we have to really validate if that's, we have to learn more about that as well. So where is the closest hospital, perhaps? Where does your ASC have a hospital agreement? These type of questions, or other QI indicators such as on-time starts or quarterly QI activity in these ASCs. On the resources side, we're thinking about how we can work with MASA to say what the candidates for surgery need here in Maryland. For example, speaking with folks, Marylanders are asking, how do I know if I'm a successful candidate for an ASC surgery over an HOPD surgery? So what do you need to know to be a successful surgical patient in these settings? For example, what can and can't you do? A lot of these administrators were telling me they have a lot of problems with patients, especially in metro areas, taking Ubers home, which create a lot of problem in their facilities. So really a awareness campaign for consumers. How do I know if I am a candidate for an ASC surgery? And also we could discuss, does your ASC have a disaster plan in place? These type of things that are just beginning to be discussed at MASA now. On the provider side, we are looking at putting more QI tools, perhaps benchmarking some of the other ones I mentioned, and how we can do outreach to help MASA in their efforts. So in conclusion, I would like to use CQMR's existing advisory committee to draw expertise from, and as needed, perhaps enlisting sectoral specialists, especially anesthesiologists and surgeons, other HOPD and ASC administrators, to glean the knowledge that we need to move forward. We're going to do continued data dives, hoping to establish and work on some of these technical work groups. And I am planning to be at the ASCA meeting in April, and that has a state association pre-meeting, which I believe will be very, very useful in lessons learned from other states. So I want to thank you for your time, and I'm happy to answer any questions you may have.
Thank you, Ms. Johnsey. Commissioners, are there any questions? To Marcio.
On page 12, I will say that I am very interested in the within 72 hours of care going to a hospital. I think that is a very interesting perspective, especially as specifically in Havre de Grace, we're going to be going from a hospital to a freestanding medical facility, and the ancillary surgical care that will be happening on that site supposedly sometime in the future.
Right.
So that would be something, because that talks to a larger issue that we have as far as how far it is to transport to a hospital from our region, et cetera. That's a significant issue. I also want to know, are you looking at doing medical cost comparisons as well, similar to what we're doing with hospitals?
Yeah, I think we are going to be aligning with the other cost initiatives. That's a good point here in MHCC, and doing our best to streamline efforts across the center.
Okay. I think that would be wonderful quite interesting to see the cost differences between the facilities so that people can make more educated decisions on where to go. Indeed, I think that, yes.
Yes, Commissioner.
Oh, congratulations. This is great. It's a very important effort, and I applaud your approach to this. It's been wonderful. I would just to highlight a couple points that you made and encourage them. One, you talked about learning from other states, and I've said this before, but we are way behind the curve nationally in terms of ASC development, and we have a different landscape in ASCs than other states have. So we have a preponderance of one-room surgery centers because our CON process encouraged that development with associated procedure rooms. That those POSCs may develop into 2 rooms over time. They may or may not. But it'd be very interesting from a quality standpoint to compare those to the multi-room ASCs because I don't know that the infrastructure in the one-room ASCs is as robust as it is in the multi-room ASCs. And the safety profiles may be different. So it'll be very instructive for us to understand what we've done in creating this regulatory environment that we have. And benching that versus the rest of the country. That will be very important.
Indeed, I'll definitely highlight that for us.
That's an excellent point.
Yes, you talked about the 72-hour readmits, and that's compelling and interesting. But when we measure hospitals, we measure them on 30-day readmits, which is a much more stringent standard. So I think it would be interesting for us to understand the 30-day readmit numbers also. So how often within 30 days of the procedure does the patient find himself or herself in an emergency department or back in the hospital? Because I think that's an important quality measure. Some of the measures that you listed were, I would say, less than compelling. The number of staff that have had their influenza vaccination is interesting, but that's not a very high bar for quality and success. Patients want to know they're not going to get the flu from one of the healthcare workers who's taking care of them, but I think they're looking the bar that they have in their own mind for U.S. healthcare is a little bit higher than that. So we need to push that.
I agree.
And the process measures around the surgical checklist are important, but again, that's not. We need outcome measures, not just process measures.
Yes, I agree. And I think we can use some of the NQF endorsed measures to move forward in that space. These CMS measures, I'm sorry, I don't have, these are them, I don't know if you can see them, but this is the list of 14 ASC measures. And really, we're using this as a starting point, a jumping off space, because we want to go with the CMS-driven initiatives to begin with.
Yep.
And so we are going to use both the ASC and the outpatient measures. Here is the 32 CMS outpatient measures, and especially highlight those
That's the 32
areas.
I was thinking of. Yeah,
Yes,
exactly.
especially highlight where they overlap to begin. But we have lots of ideas that we'll be bringing to you. Don't worry.
Thank you.
Yeah.
And, on that point, I mean, you have a couple of surgeons here on the commission.
Yes.
Do not hesitate to reach out.
Wonderful.
I'm volunteering their
Great.
time.
Great. That's
You
wonderful.
hear that? Yes. Okay. Commissioner Thomas.
I was curious when you mentioned oral surgery. So what I want you to do, since that happens like in a dentist office, elaborate what you mean when you say oral surgery in this context.
So prior to coming to MHCC, I had my own consulting, and I worked for DentaQuest Institute. And I learned a lot about what happens in the oral surgery space here in Maryland. And they are looking at quality in a way. And having been in consultation with Andrea Hyatt, she said that they don't really have any members from that community in the MASA membership. And so that cross-fertilization, that learning between the groups is not currently happening. So I envision this being an area where we can bring QI tools and other learning together with the oral surgery community.
Commissioner? Any other questions at all? Thank Thank you very, very much, Ms. Johnson. It was a wonderful presentation. Thank you. Ben's going to give us an overview of some upcoming initiatives. Ben, would you like to share some of that?
Thank you, Mr. Chairman. I can promise you that the February meeting will be a bit longer. We have a few health IT presentations that we hope to roll into I guess I would call it a compound presentation that focuses on lessons learned from some of our recent telehealth small pilots, as well as an update on adoption of health IT in both the hospital and long-term care settings. What we hope to do is take the telehealth reports, meld it with some of the comprehensive and health hospital assessment information, and see if there's ways in which we can, what we've done in a small scale can be taken to a larger scale using our resources perhaps, but perhaps others from within the department. There's a renewed effort in, I think, in pushing telehealth in Medicaid and some of the public programs that we would like to take advantage of. We'll also bring back for final consideration the state our regulations on electronic advanced directives. We've set up a recognition program. We're working with CHMA, or Maryland Department of Health, on at the same time an engagement program to promote use of advanced directives across the state. We expect to have a significant certificate of need application in February, and we'll also be presenting on our findings from the APCD medical care database on the experience of the privately insured in Maryland in 2016. I think that should inform some of the discussions that are going on in the state currently on changes to individual market and other insurance products here. So we think getting that out in February is going to push the staff, but I think we want it to be timely with discussions down in Annapolis. We also will, in February, be highlighting work that we are doing in collaboration with the Network for Regional Health Initiatives. As you know, we've been collaborating with 5 or 6 other states/regions through ENRI, and our total cost of care results will be made public by ENRI. We'll be working with you all to make sure that information is available, and also with our government relations folks at the department to get that information out. It will show Maryland has, on the private side, lower total cost of care, than risk adjusted than some of the other regions, which I think flows into what are the strengths of the Maryland model, which are that because we have historically been able to avoid the cost shifting from the private market to the privately insured market, that the private market is for particularly institutional services is a lower cost than in other regions where cost shifting is rampant. So a pretty big agenda for February, I think, and of course will probably be in the full midst of considering legislation at the same time too. So, would also note that we overlooked an Iowa-trained staff member. Kevin McDonald was ignored, and I wouldn't want him. I know I've seen him walk around with Hawkeye T-shirts and hats, and I would want to make sure it brought it to the attention of the commission that he is also a Hawkeye at one point in his life. So thank you very much.
Yes, but we do not not have dual citizenship. Okay. One of the unhappy features of the human condition is that all good things come to an end. So, may I have a motion to adjourn? Motion? Second. O'Grady comes in second. All those in favor say aye. Aye. Any opposed? I didn't think so. Have a great week.